Dear colleagues, ladies and gentlemen, good morning and welcome to the second day of our annual CHRS meeting in Banff. It's an honor to stand before you today and we gather here to exchange knowledge, share experiences and discuss with the latest advancement in the field of electrophysiology. We have an exciting lineup of keynote speakers, panel discussion and presentation that will cover a wide range of topics, including cutting-edge research, emerging technologies, and best practice in patient care. We have carefully organized this program to ensure that it addresses to the diverse interests and specialties of the EP field. For all of that, I want to thank the annual meeting planning committee. In addition to the formal session, and I encourage you to take full advantage of networking opportunities available during the breaks and social events, so don't forget to go to the posters and to the booth in the next room. I would like to express my deepest gratitude to all of our organizers, gemstones, and the sponsors, without whom the Congress would not have been possible. I'd like to acknowledge we are on the Territory 7 territory, the traditional territories of the Blackfoot Nation, including Chickshakha, Piikani, Kite Isle Night, Chute-Ina Nation, and Stone Nakoda First Nation. Thank you, and I wish you all a productive and memorable meeting. And Laurent, it's yours.
Yes, thank you, Blandine, and congratulations to your pronunciation test this morning. So I want to say hello from home. As you know, I'm not allowed to travel, take a flight, or be in altitude because of an eye surgery I had recently. So I'll be following the meeting from here, unfortunately. I hope you had a great meeting so far. And I want to congratulate again all the awardees from the award ceremony of last night, and especially Dr. Andrew Cron, who won the Achievement Award this year. He led our society a long time ago. He was actually the first president when I started being involved in the society as the chair of the education committee. So today, again, there's a lot of great sessions that are planned. We have our international faculty. I want to thank them especially for those who have traveled, for those who took time from their busy schedule, either virtually or in person. So I wish you a great meeting, and I'll be watching over you and looking what's happening over there. Oh, hello, Isabelle. She's one of the chair this morning. So, well, have a great day, and I'm sure it's going to be a fantastic lineup of sessions.
All right. So thank you very much. I'm Leila Laroussi from the University of Montreal, and I'll be chairing the first session with Dr. Colette Schleifer from University of Manitoba and Dr. Isabelle Grace, who is virtually with us from the CHUM in Montreal too. So we are, at the CHRS, we felt it was very important to acknowledge and promote diversities of all kinds. Therefore, we have this Woman in EP session where all the panel and the speakers are women. The four women who will speak today, this morning, are among others you will have the chance to listen to this afternoon and later today, leaders in their field and at the top of breakthrough research. Let them be models for all the young women out there who would like to follow their footsteps. And without further notice, ask to Dr. Jamie Meluku from the University of Western Ontario to give us the first talk about leadless pacemakers and non-transvenous ICDs. Thank you.
Thank you very much to the Planning Committee for inviting me to give this talk today. It's a pleasure to be amongst colleagues of such excellent reputation and experts in their field. I have 10 minutes to review some of the new and exciting updates on technology in leadless and transvenous ICDs. This is my disclosure. So it's a well-known fact that pacemakers are very well-established, robust therapy for bradycardia, in fact, the only treatment for bradycardia. But they are fraught with well-known complications, particularly in the long term, primarily related to the pocket and the leads. And so physicians and industry partners have put a lot of effort into making advances in reducing the amount of hardware in the bloodstream. And so for a while, since 2016, actually, our workhorse leadless device was the Micra VR. Of course, we have the most extensive post-market experience for this device because it was the only thing available for us for a while, and we've become quite good at it. And you can see here in the post-market data to the left that the complication rates are not only lower than transvenous, but they're actually, with real-world data, the complications are lower than the IDE trial. What's new in 2023 for this device is that they've made improvements in the battery, and it's allowed them to extend it by around 40%, projecting it to around 16 to 17 years. It's not Health Canada approved yet. It is FDA approved, but they're not allowed to give us any more information than that till it hits our shelves. This is more a slightly older device, but still relatively new in the last 12 months. And so a second option for a single chamber leadless is the Avir VR by Abbott. This is the new and improved nanostim with an active fixation helix. The IDE study was published last year, and they achieved FDA approval in March and Health Canada approval in August. The device is similar in fixation, so it has that rounded dome-like electrode with an active helix surrounding it. And the difference in terms of the design improvements is that there's obviously different battery chemistry as the nanostem is removed due to premature battery depletion. The battery is 12% longer in longevity. The device itself is slightly different. It's 10% shorter and a little bit wider. The delivery system is also slightly modified, and the docking button, which the nanostem had some issues with initially, has also been modified and specifically designed for chronic retrieval. There's a number of case reports and case series demonstrating successful removal in a majority of cases, up to 7 to 9 years of implant. So very promising for patients requiring multiple devices. The interesting thing about this device over the Micra is that you're capable of passive mapping. So you can look at your electrical parameters, sensing and threshold and impedance prior to deploying. And you can also temporary pace through the device prior to deployment. So if you create a couple PVCs on your way in and knock out the escape rhythm, or knock the right bundle and a left bundle patient, then you've got some means to support the patient while the implant occurs. So this is nice images from Dr. Mondesser, who is expert in this device. You can see here, just like with the Micra, it's capable of venography to ensure that you have a nice septal position in LAO. This is the sort of torture test in the tethered position where you can ensure that the device is appropriately fixated, and this is the full deployment. Apparently, the amount of traction required to dislodge this lead is significantly higher than a transvenous device, so it's able to withstand quite a bit of torture there in the middle image. So what about AV synchrony with the leadless platform? What's new in 2023? Many of you have used the Micra AV. It's basically a VDD device that senses atrial activity through its accelerometer. It was in May 2023, the second version, the Micra AV2, was approved. We're still waiting for Health Canada approval, but a couple of the improvements is that it automatically customizes AV synchrony, something that was previously manual, so you'd have to have the patient assume multiple positions. So the device is able to do this automatically now, and it's with this new algorithm also able to improve AV synchrony at faster rates, sort of sinus between 80 and 100. Some of you who have used this device may have noted it struggles a little bit at the higher rates because at the higher rates, the signal that the accelerometer detects of ventricular filling, so onset of diastole and atrial contraction, they start to fuse, and the device has a hard time distinguishing the two, and so it creates this A7 signal. And so this new device now, can't talk about it too much because again it's not Health Canada approved, but it changes the sensitivity so that it is unable to see the A3 signal and focuses more on the A4 and A7 signal, allowing it to track better at the higher rates. It's also capable of a higher upper tracking rate, so now it's up from 115 to 135. And you can see here there's a study showing that in comparison to the manual programming, the blue, sorry, I can't quite see with my new progressives here. The blue curve up above demonstrates an improvement in AV synchrony with the algorithm programmed. Also, the AV conduction mode switch, which is basically the MVP mode in this device, is also now programmable above VVI 40. So a lot of really positive improvements with this new proposed device. But again, the main limitation is there's really no capability for atrial pacing. So for patients with sinus node dysfunction and chronotropic incompetence, this leads to excessive RV pacing, which brings us to the AVIR-DR. I think it's a very exciting milestone in development in this field. So we have now a full-service dual-chamber leadless platform. This was approved by the FDA in July of this year. And so it's paired with the AVIR-VR, which I presented just previously, but the atrial device is slightly shorter to minimize interaction with the tricuspid valve. It has subtle changes in the fixation helix. I'm not sure if you can see this here, but in the ventricular helix, you can see that the bevel is tapering outward for improved penetration into the ventricular myocardium, whereas the atrial helix bevels inward to try to minimize perforation through the thinner atrial tissue and prevent it from sort of snagging the pericardial sac on its way out if it does perforate. And the other thing is, in comparison to the ventricular lead, which has a sort of dome-shaped electrode, the atrial lead actually has a pointy little helix to improve stability and electrical parameters in the much more mobile appendage. It's pokey, but it doesn't stick out any further than a active fixation helix from a conventional lead, and so the risk of perforation is still quite low. The other interesting thing, and really a game changer, I think, in the field is the eye-to-eye conductive bidirectional communication between the two devices. And so, as many of you might know, a lot of the limitations with the leadless devices is that radio frequency or wireless communication between the devices requires a lot of energy. And so in order to be able to keep the devices small, they had to figure out a different way for the devices to communicate. And so they've come up with conductive galvanic communication between the devices, where it essentially uses the blood and tissue as a conductive medium, which has allowed them to minimize energy consumption significantly. So the results for this device, the IDE trial was presented at CHRS last May. It was a prospective multi-center single-arm study, 300 patients from 55 centers across US, Canada, and Europe. And of significant pride for us here in Canada, there were 5 centers that were highly involved in the study: Calgary, Montreal, Newmarket, Halifax, and St. John's. The indications were primarily a sinus node dysfunction and heart block. There was a 98.3% success rate. The primary efficacy endpoint of atrial sensing and capture was 90%. The secondary endpoint of greater than 70% AV synchrony was 97%, and the safety endpoint was 90.3%. So the complications at 3 months, there were 35 complications in 29 patients, and you can see a good chunk of them were fairly minor, so atrial fibrillation, which can happen in conventional implants. The majority of complications occurred within the first 2 days, so they're fairly acute. There were 11 dislodgements, so 3.6% incidence of this. 5 were atrial, and 1 was unfortunately dislodged by the ICE catheter. I think, it sort of seems high at first blush, but again, remind ourselves this is like essentially a first in human chronic study, and so, these numbers will be a little bit higher, just like in the micro trial, and we'll probably see in the post-market approval registries that these numbers will come down as our experience improves. There were 2 effusions, one required drainage, and the other was just observed. So here's a video provided by Abbott with the atrial lead in tether mode, and you can see that the device is, the tether is quite a bit longer to allow the device to wiggle around a little bit more, and as released, the RV lead here in the LEO projection is down on the ventricular septum, and this is what it looks like fully deployed. So very exciting, I think, for the leadless field. For ICDs, there's a published methods paper on the modular device by Boston Scientific. This is the subcutaneous ICD paired with a leadless device. And they're looking at safety endpoints that are procedure and device related, as well as some efficacy endpoints looking at the ability of the device, the 2 devices to interact, also using conductive communication. Something that's going to hit our shelves probably later this year, early next year, is the extravascular ICD. And so this was granted TÜV approval last month for clinical use in Europe. This is a extravascular ICD with the lead implanted below the sternum. And so it's directly adjacent to the myocardial surface, which allows it to provide antitachycardia pacing. Because you're not going through bone and muscle, then your DFT threshold's lower, which allows you to improve your battery longevity and maintain that small pulse generator footprint in the anterior axillary pocket. The chronic data was presented in CHRS last month, showing a 92% freedom from major complications. There were 3 lead fractures, which had the same mechanism of injury at the same site, so they've revised the lead slightly at some welding site at the proximal electrode. There was a 98.7 defib efficacy at implant with ATP avoiding shocks in almost half of patients, and 100% discrete shock success in spontaneous events. The main concern is inappropriate shocks, 10% at 1 year. Half of them were from P-wave oversensing, but there's been a new algorithm that's been designed. Even without the algorithm, they've had no P-wave oversensing since August of 2022, so likely related to sort of a learning curve with the implant. Nonetheless, Dr. Swerdlow presented the performance data of a new P-wave oversensing algorithm, which essentially looks at alternating P and R wave amplitude and cycle length, which has been able to reduce the incidence of P-wave oversensing by around 78% when they run the pivotal EV-ICD data through a computer simulation. So in summary, we've had some significant advances this year in dual-chamber leadless pacing with a full-service dual-chamber device. There's increasing evidence for retrievability, which I think is a major concern for many of us in putting these leadless devices in younger patients who may need multiple devices. But the safety for atrial device retrieval is obviously still unknown since this is a fairly new platform that's hit the market. There's a bit less real estate and thinner tissue, so the number of times we can do that in the atrial appendage is unclear. The non-transvenous ICD platforms are also maturing now, a real promising alternative for patients who require ATP. And the last probably gap clinically is that we still don't have a clear path for patients who require conduction system pacing or resynchronization. Hard to imagine how we will achieve this without putting anything in the vasculature. But we've come quite a distance just in the past couple of years with everything else, so it might be a different story next year. And with that, I will end and field some questions. Thank you.
So thank you very much for a very, very good presentation on these new advancing technologies. So I will just see if there's a questions from the floor, if there's someone who wants to take a question. Otherwise, one of the things that I really think about is that we're going to go forward with these technologies. And do you have any idea of these combining technologies that we can do with ICDs and leadless pacing? Have you seen across anything from that?
There's a number of case reports that have demonstrated the MICRA and SICD are able to live reasonably well with one another. Not a whole lot of data yet, but I think we're all sort of waiting for the modular ICD to come out to have a fully market-approved platform. So I think, people are doing it. It's not common, but I think that's sort of what Boston Scientific is aiming for.
I will see. So due to time, I don't know if there's a question from the floor. Otherwise, I will have to thank you so much for a good presentation. I don't know, I don't see the floor, so I don't know if there's someone who wants to.
Go to the mic, please, for the questions.
How safe is that substernal implant, Jamie? Is there risk of major vascular injury with the?
I think that it's going to be an interesting effort on Medtronic's side to try and get our community to adopt it, because it is a space that we are not used to. We like to stay outside the rib cage, and the idea of putting a trocar under the sternum directly pointed at the heart is a little bit unnerving. And it's kind of like the MICRA. I think, personally, when I first heard about it and I saw that huge hose of an introducer sheath, I thought 27 French is kind of big and a little old lady. I'm not sure this is going to work very well. But when you actually get your hands on it and you do the implant, it's actually fairly straightforward. It's going to require a little bit more resources, I think, because the GA and just like with the subcutaneous ICD, the DFTs in the beginning until we get comfortable with the implants and the performance of the device. So to answer your question, the data suggests it's safe in multiple operators' hands. It's going to be interesting to see how it performs post-market in the real world, where less experienced hands are handling the device. But I think only time will tell.
Thank you very much. Due to time, I'll have to go forward, but please pick Dr. Malenkou's brain afterwards. So we'll go on to our next speaker. So I'm very pleased to introduce Dr. Jacqueline Josa from McGill, who's going to present on LBPP in 2023. So she's the lead investigator in a trial evaluating the role of left bottom pacing in patients with heart block, and she's the chair of the CHRS Device Strategy Committee and the Electronic Device Guidelines. So thank you so much for being here with us.
Okay, thank you. So I was thinking about what to present for this. And I was going to consider presenting, what are the trials, that have been done and kind of get all boring. And then I decided, these are my disclosures. I disclosed that we are not surgeons. This is LBB pacing, quote unquote, by a surgeon. We are electrophysiologists. So I really wanted to focus this talk on, doing left bundle branch pacing correctly, okay? Not deep septal pacing, not LV, we really aim for the best. We are Canadian electrophysiologists. I think we should really aim for the best. And so I'm going to go through a little bit of this document as well as other sources just to discuss how to properly implant, or not how, but how do you know that you're really at the left bundle. Okay, so now left bundle branch pacing is called left bundle branch area pacing. It's left bundle area because there's many places that you could potentially put your lead. So there was initially, His bundle pacing where proximal or distal. There's true left bundle pacing where you're really in the main trunk of the left bundle. Septal, LV septal pacing, so you're quite far, almost at the left bundle, but not quite there. You have left fascicular pacing, and that's all part of left bundle area pacing. And then there's something new called right bundle pacing. Some people will pace the right bundle and the left bundle to really create even nicer physiologic activation. So that's kind of where we are now. And these are the actual definitions, but you don't need to look at them so much as looking at this kind of idea where conduction system pacing and left bundle branch area pacing really overlap with left bundle branch pacing or left fascicular pacing, left ventricular septal pacing, where you're almost at the left bundle, is part of left bundle area pacing, but not necessarily true conduction system. And importantly, deep septal pacing, like that surgeon's implant, that's not conduction system pacing at all. So that's just drilling the lead where you think that it might be good. So this is from the left of the screen to the right of the screen is a lead that's actively being screwed into the septum until it actually reaches left bundle branch capture. So you can see RV septal pacing here. Let's just look at V1, in fact, okay? So V1, it's the classic kind of left bundle look. Go deeper into the septum, it still has that left bundle type of look. So it hasn't really changed. Now, all of a sudden, you get to the LV septum, and you see an R prime, right? So you see that so that's the definition. You have a R prime for sure in the LV septum, but you're not quite there yet. And when you get to LB capture, you have a lot more latency before the CHRS, okay? That's just looking at it from a morphology standpoint, but I'd like through this talk to actually, and at the end of the talk, we're going to analyze a few ECGs to see whether you think they're deep septal, LV septal, left bundle, true left bundle, and so forth. Just wanted to again say that a lot of these implants are actually fascicular pacing, and so left bundle fascicular pacing could be pacing the left posterior fascicle. Here, where you see lead 2 and 3 are quite negative. You can be pacing the anterior fascicle where they're positive overall, and septal pacing, which usually lead 2 and lead 3 are opposite of each other because we're on the septum. So I mentioned a little bit about this yesterday, but I'm going to go through it again. So when I do left bundle pacing, the first step is to look for is to look for a transition during decremental pacing while you're unipolar pacing, okay, not bipolar, unipolar, and that's the gold standard, and we see that in about 20% of patients where there is going to be a transition from non-selective to selective or non-selective to septal, and if you see that transition, it doesn't matter which one, that is true, you're truly on the left bundle there, okay? So, let's go over it. So the first on the left side is non-selective to LV septal pacing. So we're kind of not perfectly on the left bundle, okay? So what are you going to see when you transition from a high output to a low output? So high output, we're capturing both the septum and the left bundle, but when we come down, we're only going to be capturing the septum, and therefore our left ventricular activation time, which is measuring the activation from here to the left ventricular lateral wall, if we're going to be capturing the septum only, all of a sudden that's going to jump out by at least 10 milliseconds. And that's kind of the definition for the transition between non-selective to LV septal pacing. You're also going to see a loss of this S wave here in V6, and also V1 is going to get the R prime is going to get a lot tighter. Why is it going to get tighter? Because now we're activating the RV much much quickly because we're kind of closer in this area, okay? Now, when we're non-selective to selective, here you're only capturing the left bundle. So if we come from a high output to a low output, we're not going to see any change in the LV activation time to the lateral wall. That's going to remain the same. But our R prime, the distance or the time it takes to activate the right ventricle, is going to be much longer. So that R prime is going to be wider and later. So this is the first thing that will tell you. If you see this transition, you're done. You're done with your implant. Okay, then there is, we talked again a little bit yesterday about the left bundle branch potential. If you see a left bundle branch potential, that LB potential to the peak of the V6, or your LVAT, R wave peak time, same thing, that is going to be what your true LVAT lateral wall activation is. And so that's what you're aiming for when you're doing your LVAT to V6, okay? Then, if you don't have an LB potential, if you don't see that transition, the next step is to kind of look at, and we always talk about LVAT, but measuring, because it's so simple to do, your pace stimulus to the V6, the peak of V6. If you have a narrow CHRS or a right bundle branch block at baseline, then you're targeting an LVAT of less than 74. If you have a baseline left bundle, IVCD, or an escape rhythm, then you're targeting an LVAT of under 80 milliseconds. There's some caveats here, of course, and we'll go through the ECGs and you'll see those caveats, but the big one is that if you're fascicular pacing, then clearly you're much more distal in the conduction system. If you're distal, that means you're much closer to the LV lateral wall, so of course it's going to be more narrow. And so your LVAT is going to be, it's going to be a falsely narrow LVAT. So we can't just look at LVAT because a lot of the time we are actually fascicular pacing. This is probably the best, also the best criteria and the easiest one, I think, to tell you if you should keep going more deeper into the septum. And that's the V6 to V1 peak time, okay? So what is that measuring? We're measuring, essentially, V6 peak time is measuring the LV lateral wall activation. And the V1, the R prime in V1, that's where we're measuring the right ventricle activation. So, essentially, this is non-selective left bundle pacing in the middle, selective, and LV septal. So here we have so we're measuring the V6, R wave peak time here, V6, to the R prime in V1, okay? And here it's 50 milliseconds. And when we have LV septal pacing, so we're not truly on the left bundle, it's much shorter than if you measure when you're on the selective. It's much longer. So the longer you are, the better you are for from V6 to V1. The longer separation between activating the LV and the RV. It's very easy to do. So this is part of the consensus document, and it kind of goes through each one of these criteria, and it tells you if it's going to be true left bundle branch pacing based on if you hit all these criteria, or if you're kind of in between, then it's likely left bundle branch pacing, and then you can decide if you want to keep going or stop there. Okay, so let's go through a few ECGs. So this is the pre-ECG. Just nice to always look at your pre-ECG because you know what is the escape rhythm, is there a left bundle, what are you dealing with? Okay, so here we have a left bundle and we have a longish PR interval. And this is left bundle branch pacing. And the question is this deep septal capture, like a surgeon, LV septal capture, non-selective or selective capture? So just have a look at the ECG. You can have a kind of a first gestalt, or if this is a good position. And then I'm going to give you a few numbers here. So our CHRS without the latency, okay, is 119 milliseconds. The LVAT, the LVAT in V6 is 78 milliseconds. There is, when I say latency, I'd like to see latency in a few leads. I don't know if that means anything yet, but we will eventually see if that does mean something in the future. but if there's latency between the pacing spike and the QRS. And then if there's a QR present, so the R prime, so yes, there is QR present here. And the V6 to V1 peak time is long, so the V6 to the lateral LV wall to the RV activation is long. So this is definitely non-selective. It's never going to be selective left bundle, and that's not what we're aiming for. We're never really aiming for selective. That doesn't make much sense. But we are aiming for non-selective, and so this is true non-selective left bundle branch pacing. It meets all the criteria. Okay, another ECG. This is a pre-ECG. You see we have complete heart block. We have a narrow QRS. Escape. Oops, sorry. Okay. Is this deep septal, LV septal, non-selective or selective? I'll give you a quick look and you can make a guess. There's a QR there in V1. It's quite a short, I would say, LVAT. It's funny because it's notching a little bit, right? AVR and AVL are both a little negative. That's a little funny. So let's do the measurement. So QRS without the latency is 122. It's very good, right? LVAT is long. It's 92 milliseconds. There's no latency present anywhere. The QR is present in V1. And V6 to V1 is so that it's 29 milliseconds. It's too short, okay? So, and the notching is present. I don't like the notching because the notching suggests that there's probably dyssynchrony going on, but maybe there's scar present. So I don't know what to make of that, but this is definitely LV septal capture. Okay, we're not at non-selective. We're not truly there yet. Let's keep going. Timing is too much? Oh, let's go a few more. There won't be many questions. Okay, just ask them, just shout them out then. Okay, pre-ECG, it's a right bundle. Okay, this is, so let's quickly look. So V1 has a little bit of an, we'll just keep going. Look how short that LVAT is. And look where we're pacing. We're pacing the posterior fascicle, right? Okay, so the QRS is quite long, so you're like, oh, I'm pretty disappointed in my QRS, but it's not really about the QRS duration. It really isn't. The LVAT is nice and short, 71. There's latency present. There's a QR present. And the V6 to V1 is 54. Just trust me, I measured it. It's 54. How is it that long? Is this truly non-selective? Well, we falsely get, because we're distally pacing in the connection system, so of course our V6, the lateral wall to V1, our RV, is going to be very long. So it's a false representation. Okay, we're not non-selective here, we're LV septal. Okay, you can maybe use a surrogate as AVL to V1 or AVL to AVR. And those, if you measure those don't meet criteria for the V6 to V1 peak times, and we're LV septal pacing. Let's keep going. So long PR and narrow QRS. So there's no Q, what you notice here is the LVAT, it's okay, but there's no QR in V1. Why is there no QR in V1? And we talked a little bit about this yesterday. Because look how anterior we are. We're pacing the anterior fascicle practically in the membranous septum. I'm like, AVR and AVL are so negative and so positive in 2 and 3. We're never going to find an R prime in V1. So there's certain criteria we can't actually measure. We can't measure the V6 to V1. The QRS is 135, LVAT 85, latency not present, QR not present. This is probably LV septal capture. And I think this is the last one. Long PR, IVCD. So, QRS without latency is great, 125. LVAT is 88, a little bit long. Latency is present. QR is present. So although the LVAT is 88, our V6 to V1 peak time is long, it's 44. This is clearly non-selective left bundle branch capture. So you have to put everything, my conclusion here is that you have to put everything together to make sure you know where you're going. But I think we need to do this correctly. Oh, sorry, just right before I finish. So there's a few trials now undergoing. In the space of AV block in EF over 35%, we have 4. There's one Chinese study. There's LEAP, it's a Netherlands study, which is looking mostly at echo outcomes. There's us, Left HF, which is looking at hard outcomes. And then probably going to start in the next 6 months is PROTECT, which is going to be a massive trial of 3,000 patients, looking at RV pacing, all looking at RV pacing versus left bundle branch pacing. So in conclusion, I don't know what I wrote. We're not surgeons. Let's make sure to do LVB pacing the right way. Thank you.
I don't know if you can hear me. I don't know if this is on. You can hear me okay? I was just going to ask Jackie one question about what complications could we expect, particularly with people starting out with left bundle area pacing?
Starting out, I think starting out actually, you don't see as many perforations of the LV septum because we're all afraid to keep screwing further, right? And the more experience you get, actually you get more perforations of that interventricular septum because we want the best outcome. But remember, and I talked about it yesterday, there's no clinical sequelae of going through the septum. I mean, sometimes we do make a little bit of Swiss cheese out of the septum, but I think that there doesn't seem to be any problem with that. There's potential many complications, but I think they're relatively comparable to standard RV pacing. I think that would be a whole other talk.
Great, thank you. So next up, we have Dr. Julia Cadron-Tournay. Julia is going to speak to us on an update on the management of cardiogenetic patients.
So hi, everyone. It's a pleasure to be here. Thank you for inviting me to present in this city that I really love. So in the next 10 minutes, which I think is a challenge, I'm going to talk about new things in cardiogenetics. My disclosures are a consulting fee with two companies doing gene therapy trials in RVC. So it's relevant for the end of the presentation. So during the next 10 minutes, I'm going to go through 3 different topics. I could have chosen other things, but I decided these 3 ones because I think it's very interesting and timely. So first topic, explaining the unexplained cardiac arrest. So one frustrating part of working in a cardiogenetics clinic is patients with unexplained sudden cardiac arrest, because we don't necessarily know what to tell the patient after this dramatic event, and mainly in family members, we don't really know how to follow them and how to reassure them. But the good news is that it is improving, and there are different paths to improvement, and I'm going to touch 2 of them. First, genetic testing. So a nice study from our Canadian CHRS registry in patients with unexplained cardiac arrest, published last year, showed that genetic can help refine the diagnosis. So in fact, in these patients who had unexplained cardiac arrest, so all these, their tests, clinical tests at baseline were normal. 10% of them had pathogenic variants in genes that can cause sudden cardiac arrest. But I think even more interesting is the concept of concealed cardiomyopathy. So in 6% of these patients, the variants were in genes causing cardiomyopathy, but as I mentioned, their heart was totally normal at the time. So this brings the idea and highlights that these genes causing cardiomyopathy, especially arrhythmogenic cardiomyopathy, can produce, as a first event, cardiac arrest before there's overt cardiomyopathy. A second topic is a real new disease called calcium release deficiency syndrome, which got a lot of interest since its first, let's say, discovery in 2021. So what is it exactly? It's a disease causing, of course, sudden cardiac arrest, but caused by ryanodine receptor loss of function. So you might know this gene RYR2 because it's the gene mostly causing CPVT, but here the mechanism is the complete opposite. But it also causes sudden cardiac arrest. The problem with that disease is that the phenotype is concealed. So we don't see anything on normal clinical tests that we do in clinical practice, and that's probably why we haven't known about this disease until recently. So how can we make the diagnosis? So this is work in progress. First, patients have variants in the gene RYR2 that need in vitro to be classified as loss of function. So this needs a lot of work. And second, there's a clinical test, so what was described as a programmed ventricular stimulation protocol, as you can see here. So rapid pacing and then inducing a pause and then in a short interval could induce VF in these patients. So inducing VF in patients as a diagnostic test is not necessarily elegant. So more recently, what was what was described and starting to be described is this abnormal repolarization pattern. You see the prolongation of QT after a simple train of rapid pacing. So this and CRDS in general is what is going to be studied in a new CIHR-funded registry and diagnosis study led by Jason Robert and Wei Chen, which will be started in Canada very, very soon. Second topic, risk stratification in, air quote, arrhythmogenic cardiomyopathy. So you might know about the original ARVC risk calculator, which was published in 2019 already. So that's not news. 7 predictors, so you can get with that predictor available online, the risk for a specific patient. So what's new about that is that it's now been well externally validated in 2 large studies. And in one of these 2 studies, there was a large participation of many Canadian centers, and I see many of you who participated through the HERO collaboration. And there was another completely independent study from the UK. So this pretty much says that the model works well, that it can be used in patients, but it doesn't work as well in some specific patients. So those in whom it works the best is normal classical ARVC, but in some rarer but important genes, such as desmoplakin, DSP, not deep septal pacing, it doesn't work as well. Now, the risk calculator has been integrated into the guidelines just recently in 2023, the ESC cardiomyopathy guidelines that were released during ESC this year, and they make it a 2-way recommendation to use the prediction model for risk stratification in ARVC. And the other new thing is that we can use programmed ventricular stimulation to improve the results we get with the model. So we showed in the past year too that using programmed ventricular stimulation in ARVC can help predict ventricular arrhythmia events. And this is mainly useful in patients with not a too high risk, in whom we would implant an ICD anyways, no matter what the result of programmed ventricular stimulation. So less than 25%, negative predictive value is 93%, so helpful to delay the implantation of an ICD. And we can also use programmed ventricular stimulation to refine the prediction we get with the model. So this is now available online on the same website. So going more globally about risk stratification in cardiomyopathy, we are, I think, entering in the genetics era where we more and more realize that genotype might be, in certain cases, more important than phenotype when trying to have the prognosis of patients, be it arrhythmia or heart failure. And this is now well recognized for several arrhythmic genes for which we have specific predictors. And for some of them, lamin, PLN, we now have prediction models that we can use. They have not been externally validated in large samples, but still can be useful. Another one is also coming for another, I think, important gene, desmoplakin. We should see that coming in the next year. So last topic, but I think very exciting one, is novel treatment. So how we treat usually patients with rare cardiogenetic disease, we apply the usual medication that we have for other diseases, antiarrhythmic drugs, heart failure medication. But targeted therapies are coming, and they're coming pretty fast, and I just want to talk about 2 of them. First, gene therapy for ARVC. So ARVC caused by the most common mutation in ARVC, PKP2, is a good target for this kind of therapy. So how this gene therapy works, a viral vector, so pretty much a virus, is injected in patients, and its virus includes RNA and the virus infects the cell. The RNA gets translated into a protein that is deficient in the patient, and this new protein patches the disease desmosome in these patients. So a mouse model has revealed that it works well, and the FDA endorsed an investigational new drug. So pilot trials are coming probably in the next year, so we'll be excited to see that. Another avenue is a small molecule called tideglosib, which has been shown to work in a mouse model of ARVC, but this time for different genes, not only for PKP2. Interestingly, this molecule has been used in humans in the past for Alzheimer's. It didn't work for Alzheimer's, but it was safe. So where are we at with that? So there's a phase 2 clinical trial starting also in Canada, led by Jason Roberts. So we're very happy to participate, and I hope you are. So in conclusion, I think unexplained cardiac arrest is still frustrating, but we are slowly getting better. ARVC, we have a risk calculator. We can use program venture stimulation if we're unsure about the decision of implanting an ICD. Gene-specific understanding, I think, is really where we are and where we're moving at. New therapies are coming, and I think this is very exciting. And I think in this whole presentation, you see that teamwork is very key in these rare diseases and working all together. And we're lucky to have that in Canada through the HERO, formal or organic network, I don't know. So that's another message. Thank you very much.
Thank you, Julia. This was a great talk. Is there any question in the audience? I might have one actually about the loss of function of RYR2. Do you think that now we have enough data to do an EP study, like through the device, or a real EP study on all the patients where we don't have any cause for ACR, for cardiac arrest, or do you think with the genetic panel it will be done already or not?
So specifically for CRDS, so I think, first these patients have variants in RYR2, and now since I think there is this trial starting, what I would do is include the patients, always one patient, one study, so include the patients in the trial. The in vitro testing to know if the variant is a loss of function will be done through the trial with no charge or no problem, and the protocol can be done through that.
Enroll. Always.
Enroll.
Give me that question. No. All right. If there is no other question.
Andrew.
Okay. Oh yes. Please can.
Quick practical question is how often are you actually doing program stim in ARVC patients?
That's a very honestly not very often.
Julia, can you just repeat the question because we didn't.
Oh yes, sorry. So the question is, honestly, how often do you perform program venture stimulation in ARVC patient? And the answer is not very often. I think most of the time we have enough data, especially with the risk calculator, to know what's the risk of the patient. So we have been lucky in this trial because there are centers, particularly in Europe, who did that as a standard of care. And we had a lot of data from that. But in my real practice, I don't do that very often. More in patients where you disagree with, patient doesn't want an ICD or wants an ICD and you don't want to implant to resolve these kind of things. But I think most of the time we have the information with non-invasive tests. And I think one non-invasive test that I really like is the Holter and the number of PVCs that we see evolving through time. And I think this gives us a lot of information. And I mean, it's an easy test, easy to perform, non-costly. So I think there's a lot of information in there.
Great. Thank you. Can go with our last speaker, who clearly doesn't need any further introduction, Dr. Blandine Mondésert, who organized for us this great meeting, and she will talk about one of her other expertise field, which is the management of arrhythmia during pregnancy, introducing the new HRS expert consensus.
So thanks for the introduction and good morning again. For once, I'm not going to bore you with the SICD slides. So as part of the congenital team in Montreal Heart, I have to deal with pregnancy in young women, especially the congenital one. And so I have the pleasure to be part of the expert consensus at the CHRS, presented this year in New Orleans and now published, finally, after 5 years. You should have received an email this week about the CHRS, saying that there is the publishing. So arrhythmia during pregnancy, thankfully, the more frequent arrhythmia during the pregnancy are the benign one. So atrial premature beat, ventricular premature beat, atrial arrhythmia are very frequent. VF and VT are less frequent, thankfully. So I just want to go through clinical cases. It's a 40-year-old woman. It's his sixth pregnancy with a 26 week of gestation. She had already palpitation in 2012, with beta blockers, and now she's consulting in the ER. And here it's the ECG, so it's real life with a very bad quality of ECG because she's consulting not in Montreal Heart at that time. So you can see a narrow CHRS with the sign of the round. So you can see P wave, retrograde P wave. So it seems to be the SVT diagnosis. So if you look at the CHRS consensus, you can see that in the acute management of the SVT, you can do vagal maneuvers, you can do adenosine, or if you need, we can do the DC shock. And for the DC shock, we have done a statement on how to do that. So especially how to place the pad for the DC shock. So if you need the DC shock for more ventricular arrhythmia, we recommend to put the sternioapical placement. And if it's more for the atrial arrhythmia, we recommend more anterior posterior electrode placement. And every time you have hemodynamically if you have unstable arrhythmia, you can do cardioversion in pregnant patient. So here it's after the adenosine. So she had the IV adenosine, and you can see normal ECG, normal PR, no pre-excitation, nothing wrong in the ECG. So what's the next step? So in terms of antiarrhythmic drugs, you can give actually almost all the antiarrhythmic drugs that you want, except the atenolol. It's a contraindication. In terms of other antiarrhythmic drugs like the flecainide or all the class 1C medication, you can give that. You have to be cautious with the amiodarone. It's very in the second intention. If you use the beta blockers, you have to be careful about the baby in terms of growing size, and also in terms of hypoglycemia at the birth. So the recommendation for the long-term management of the SVT, so in our case, in absence of pre-excitation, metoprolol, propanolol, digoxin can be used. Verapamil as a second line. Also, if the patient is refractory to the medication, you can use the flecainide, the propafenone, or the sotalol. And if, once again, she's refractory, then you can go further with the ablation, the catheter ablation during a pregnancy. And actually, we have now several studies and data on ablation and actually radio exposure for the fetus. And you can see that the RF ablation is around 2 CT scan as maternal exposure, but for the fetal exposure, it's around 2 angiogram. The exposure is bad for the first 8 weeks. It's a yes or no for fetal anomalies, but actually the threshold for no fetal abnormalities is 50 milligrays. So you see that the RF ablation, it's 15 milligrays. So we are way beyond the threshold. So we can do that. We recommend to do the ablation after the first trimester, if possible, with the always the ALARA things, so as low as reasonable achievable radiation exposure. It's better to do that in some center who used to do that. You don't want to do your first zero fluoro ablation in a pregnant patient. And you have to be, you need to have a cardio-obstetric team around you, and that team should be aware about all the complications that you can face too. And you have to be ready to do urgent delivery if the baby is available. And we don't recommend anymore a pelvic lead apron because there is no data that show a benefit to use that. Most of the time, it's not well opposed, and then it's on the other way, increase the radiation exposure. So we prefer to not recommend the pelvic lead apron for the patient than to put that on the bad way. So our patient, a few days after the conversion with the adenosine, she came back with a symptomatic AFib, less than 6 hours. Actually, she had a cardiac system, so we can see for real the AFib. And she had a spontaneous termination in the ER. So how can we integrate the patient during pregnancy? So usually we can discuss that with the obstetric team. If the warfarin is less than 5 milligrams daily, you can pursue the warfarin during the first trimester, the second trimester, and perhaps the third one, and we have to stop around the delivery date. And if it's more than 5 milligrams, you have to stop the warfarin or to discuss with the patient and say, okay, there is a higher risk for fetal abnormalities with high dose of warfarin. So what do you want? What do you choose, warfarin or heparin? And then you have to stop the heparin also during the third trimester. Our patient was on beta blocker and aspirin just because an obstetrical reason, because she's like older than usual, so 40 years old. And she had a premature delivery at 34 weeks. Actually, what are the recommendations for delivery? The route of the delivery is, once again, a team chair decision with the obstetrical team. It's very rare that for arrhythmic reason, we ask for a C-section. And the other thing that is important is that you don't have to stop any antiarrhythmic drugs for the delivery. And actually, there is some data showing that the higher risk for arrhythmia in patients known with arrhythmia and with antiarrhythmic drugs is the postpartum period, because most of the time, the antiarrhythmic drugs have been stopped. So we don't have to stop the beta blockers of the antiarrhythmic drugs for the delivery or for the C-section. The anesthesiologist can deal with bradycardia, low pressure, whatever, but you need to have the beta blockers on board during the delivery and the postpartum period. Here it's the classification of the antiarrhythmic arrhythmia, that can deal with some complication during the delivery, and you can see that the high-risk arrhythmias are the CPVTs, and all other the inherited arrhythmia syndrome with recent arrhythmia. So once again, we have to share the decision with the obstetrical team. Usually, I follow the patient with ICDs every month during the pregnancy with the home monitoring, just to be sure that there is no non-sustained VT. And then around the beginning of the third trimester, we have a meeting with the obstetrical team, and then we have a plan. Plan A, Plan B, Plan C, and plan to deactivate the ICD if the patient is going to C-section in emergency. So most of the time it's a magnet on the device. So our patient have incessant SVT after delivery, refractory to beta blockers. So we perform an ablation 8 days after the delivery. That was a left lateral pathway. I don't know if you remember the retrograde P wave with V1 looks like that. And we did that with RF ablation and sedation with minimizing fluoroscopy. We don't use the zero fluoroscopy at that time as she already has her delivery. In terms of breastfeeding, there is no contraindication of propofol, neither fentanyl during the breastfeeding. So she doesn't have to stop the breastfeeding because of the procedure. Once again, the antiarrhythmic drugs should be used when it's clinically indicated. And if the patient was on beta blockers first, you have to continue that during the breastfeeding. You have to be very careful about the amiodarone, but actually most of the time with a shared decision with the patient and the obstetrical team, we can pursue the breastfeeding or we can stop it. It depends on the risk for the patient and for the medication and for the baby. So in conclusion, thankfully, the incidence of arrhythmia, increased during the pregnancy, thankfully benign most of the time. We need a multidisciplinary discussion and a shared decision, actually, with the pregnancy hot team. We can use most of our antiarrhythmic drugs during the pregnancy. We have to be careful about the atenolol and the amiodarone, but otherwise, you can use it. We don't have any data on the new antiarrhythmic drugs, on the new anticoagulation drugs, so the NOACs, we don't have any data on that, so far it's not recommended. We can perform ablation and we can perform zero fluoroscopy ablation in our patient. And now we have two different guidelines to help us. The European one published in 2018, more on general cardiology, and the CHRS consensus published this year, more based on the arrhythmias. So it's just an overview of the guidelines. We try to be very, very practical. So if you have any question on that, just go in the guidelines. We have done all world session on VT, how to manage VT during pregnancy. And also we have done a session for all the inherited arrhythmia syndrome by type of syndrome. So we have tried to be as practical as we can. So thank you, and if you have any question.
Any audience questions?
Jackie
right
as
there,
well.
yeah. Can you use the microphone?
Yeah.
Thank you.
Safety of intravenous sodium channel blockers if you need them for VT.
Actually, if you need IV channels blocker, you can use that. Most of the time we use that on the second line. We tried the beta blockers first, but if we need, we can use the verapamil or whatever you want. Or the procainamide. You can use that also, but once again, second line. But there is no real contraindication to that.
Couldn't take it at the initial part of breastfeeding, so those first few days you had to hold it, maybe, right before delivery. It was always difficult to time, and then afterwards chronically long-term breastfeeding or whatever, it was fine. Is that still the case or no?
There is some data on that. We recommend perhaps on sotalol to not breastfeeding at that time, especially if the patient has some recent arrhythmia. Otherwise, we can change for just beta blockers, regular beta blockers. But if you really need that, you can take the sotalol at the beginning of the breastfeeding. But we recommend to try something else if we can. And I have just a comment. It's amazing doing that guidelines or consensus. Speaking with obstetrician, they are so afraid about the arrhythmia, and we are so afraid about the baby. And the answer that I get every time is, just think to the mother first. We don't care about the baby, and if it's good for the mother, it will be good for the baby. So it changed my way to see things.
Merci, Blandine. You mentioned having a cardio-obstetrical backup if you perform an ablation. Like, practically, how do you do that? Most of us, we work in hospitals where there is no obstetricians in the hospital.
Yeah. So in Montreal Heart, we have our obstetric and pediatric hospital just 45 minutes away if there is no traffic. So actually, we have a lot of meetings with the obstetrical team every 6 weeks. We are speaking about all the the pregnant patient with a cardiac issue. We have recently done one C-section. It's not an arrhythmic decision. That was a hemodynamic decision with the mitral valve parachute in a patient, and she was unknown with that diagnosis, and she arrived in Montreal Heart at just the beginning of the third trimester. We tried to manage her for 2 weeks, and then we organized in the OR, in the cardiac OR, the C-section first with all the team coming in Montreal Heart. Then we do the C-section, the neonatology team take the baby back to the pediatric hospital, and then we do the surgery for the mitral valve. So we can do that. It's very rare that we have to do that. On the other hand, in the pediatric and obstetrical hospital, they have all a protocol for aortic dissection in case of, for the Turner or the Marfan patient. So they know how to deal with that, and they know when they have to call for assistance or something like that. So there is a lot of protocols.
Okay, so, but you do not recommend in-house obstetrician if you perform an ablation?
No, no, especially if you do that before the 24 weeks, the baby is not available, so there is no thing to do. And after that, usually I just take the echo probe, check the heartbeat of the baby. It's supposed to be twice the heartbeat that the mother around. And if I have some issue with that, I call the obstetrical team, and then we organize a follow-up in the hospital.
Can I just ask one final question, Blondine, on if device implantation is required during pregnancy, what strategies to reduce radiation?
So once again, if the mother needs a device, you have to implant the device. You can't postpone the implantation of the device if it's indicated. We have done a few with as low as you can as a fluoroscopy. It went well. The baby was well also. We tried to not perform that during the first trimester. That's why when the patient, especially the one that I follow, want to be pregnant, I say, okay, just come to me before. I don't want to be part of all your plan, but I just give you my approval to be pregnant, just to be sure that we are not facing some surprise, but you can do that. And if it's recommended for the mother, you have to do that, for sure.
So I think we are exhausted our questions. Maybe others will come up later on during the day, so you can always go to our speakers. So I really would like to thank everyone that attended this session this morning, and to my co-chairs and speakers. I think we started day 2 beautifully with a very nice session. So thank you also to the planning committee to have allowed me to be part of this session, even though virtually, because I'm leaving for Compostelle this weekend. So I was not able to make it to Banff. So thank you very much. And just to a last teaser, maybe, there's going to be a Canadian Women in EP event during CCC on Thursday, night 26. So just save the date. You'll have more details coming up soon. So I just wanted to give you an update from that. And thank you very much to everyone. So I'm returning to you live and to go for our next session. Thank you and goodbye.